All right. Good afternoon, everyone. Can you all hear me, I guess? So the afternoon talks are more clinical, with the common problems in Mecp2 duplication syndrome. And we have the speakers from Texas Children's Hospital, Houston, Texas. The first one will be about the infections in Mecp2 duplication syndrome. As you know, it's very common. And the speaker is Dr. Ivan Chinn. Dr. Chinn is an immunologist and geneticist from Texas Children, and he's seeing our Mecp2 duplication syndrome patients. So he's going to join remotely, and it's too early in the morning in Houston, but thanks Dr. Chinn for joining. And now you can run the presentation. Thanks, Dr. Chinn.
All right. Well, thank you, David, and have a good afternoon. So my talk today is about recurrent infections in the Mecp2 duplication syndrome, and I'm just really excited to be talking to you all this morning or this afternoon. So, here are the three things I'm going to discuss. I'm going to talk about the types of infections, what are some of the potential causes of the infections, and how strategies or options for managing them. So, this is one of the first articles, not the first, but one of the first articles that described Mecp2 duplication syndrome. Here you see it's called X-linked mental retardation syndrome. They didn't know what the gene was yet. They knew that it was located on the X chromosome and XQ28. But it's interesting, right? Aside from the neurological problems, one of the descriptions of this disease includes this aspect of multiple respiratory infections. So it was later on that the actual locus, the Mecp2 locus, was discovered. And so this is one of these papers by Van Esch. And in this article, they had 13 males or 13 patients who were affected. And if you notice, they talk about what happens to these patients. There are a lot of neurological issues here, of course. But if you look, right down near the bottom, it talks about the fact that these patients can have severe infections. And so, even from the early onset, it's been well known that Mecp2 duplication syndrome patients can have severe infections. So what are these infections? This is one of the largest database registry reports from around the world. And what you see is the pneumonia is number one, and bronchiolitis. So both of those involve the lungs. And then, second here is pharyngitis and tonsillitis. And so, they noted that over 80% of patients were hospitalized at least one time for a respiratory infection. So this is not an insignificant issue. This is the aggregate study again from multiple cohorts, again from 2022, and so here you see that again the top cause of infection or the type source of infections are the respiratory infections at 74%. One of the things to not be lost on this slide is the fact that if you look for, right here next to the bottom is sepsis. So out of 88 patients, 11 for 1 in 8 patients actually develop sepsis. So that is very scary. That's a worrisome event where you have bacteria in the blood and very life-threatening. So what are the types of organisms that are isolated from these infections? So here you will notice that the top two types of organisms are strep pneumonia and Haemophilus influenza. So these are both bacteria. Number 3 here is E. coli. E. coli is a very common, bacteria that you find in the gut and in things like the mouth. But strep pneumonia and H. flu, we'll talk about these again. What's really important about those two is they are bacteria that are encapsulated or covered by a very thick layer of sugars to help them evade the immune system. So, in summary so far, bacterial infections are common in Mecp2 duplication syndrome patients. About 3 out of 4 patients develop pneumonia at some point. Other kinds of sinus-pulmonary tract infections, ear infections, sinus infections, they do happen, but it's less frequent. And about 1 in 8 patients has been reported to develop sepsis. So, what are some of the potential causes of infections? Aspiration is clearly an important risk factor. And this is a study from Japan where they looked at they reported 3 males from 2 unrelated families, and they noted very importantly that the immune function in these boys or males was normal. So the immune system seemed to work okay, but they were having recurrent pneumonias, and the way they were able to treat the pneumonias was this procedure called laryngotracheal separation, where basically the airway is separated from the mouth and the throat, so that saliva and oral secretions cannot enter the lungs, and that's how they got rid of the pneumonias in these male patients. But what about the immune system? So this is all the way back in 2006. It was already recognized at that time that there could be immune problems in these patients. And here you see that out of 10 patients they looked at, 4 had IgA deficiency. So that's a little hint that these patients might have problems with the immune system. So let me just give you a very simple summary of how the immune system works. So we divide it into 2 categories, one being what we call the innate immune system, and the other side being the adaptive immune system. So adaptive immunity is very basic, simple immunity where they just recognize that there's something dangerous in the body. They don't know, the molecules don't know exactly what, but the molecules and cells just say there's something wrong, and they go in and produce inflammation to try to fight the infections. Adaptive immunity is something when you hear about T cells and B cells, that's adaptive immunity. So that's very specific recognition of infections. And these cells and this aspect of the immune system is able to remember previous infections. So next time an infection happens, the response is faster and more robust. So so B cells, they make antibodies to fight infections, and T cells, they more directly attack infections, as well as telling other immune cells to come and fight these infections with them. So, what are some of the abnormal immunologic findings in Mecp2 duplication syndrome children? Um, so, Bauer and his group in 2015 they looked at 21 children, and they found that IgA deficiency, so immunoglobulin A, happens in about 1 in 5, and so IgA is an important immunoglobulin that lines the respiratory tract and other kind of mucosal surfaces like the GI tract. So IgA deficiency could increase your risk for some respiratory infections. Um, 6 out of 21 patients, so a higher percentage actually, they had low IgG2 levels, immunoglobulin subclass 2. And that subclass is important because that contains a bulk of what we call polysaccharide antibodies against polysaccharides. Why is that important? I mentioned earlier that the 2 most common organisms found in infections in Mecp2 duplication syndrome patients are strep pneumonia and H. flu. And they have this very thick, as you see here, light blue, thick capsule that's made of polysaccharides. And those polysaccharides are hard for antibodies to bind to, hard for cells to bind to, so that cells have a hard time grabbing onto these bacteria and digesting them. So you really need to have special these polysaccharide directed antibodies that are specially made by the immune system to bind to polysaccharides to help fight these kind of bacteria. Um, what other kinds of immune problems? Well, um, this group here in 2012 showed that Mecp2 duplication syndrome children can have low memory CD4 positive T cells and low memory B cells. So again, so some impaired immune response. So what's interesting is the memory T cell population seems to improve with age, and so that's encouraging. Um, the what is the role of MECP2 in all of this? I don't think it is not well understood at all. Actually, nobody knows what MECP2 does exactly in the immune system. But so this group here, you'll notice some of these names: Dr. Zogby, Dr. Corey from Baylor College of Medicine, showed that at least in mice, MECP2 having too much MECP2 inhibits T cell function, and it's these Th1 cells. Now, this is still not well worked out because the Bauer group did not find evidence of Th1 deficiency in human Mecp2 duplication syndrome patients. Again, they looked at 21 patients. Other roles, possibly for MECP2 in immune function. In mice, MECP2 is important for driving some T cell development here, maybe, but also driving innate immunity. So STAT1, STAT3, those are two important innate immune signaling molecules. And when you have too much STAT1 and too much STAT3, you actually get immune dysregulation and excess inflammation. Um, Interestingly, then in microglial cells, which are cells in the nervous system, but they are macrophages. So those are immune cells in the nervous system. When you stimulate these cells with certain activators, um, um, having too much MECP2 also increases STAT3 expression and other inflammatory molecules while reducing phagocytosis. So, um, if you have too much MECP2, you may also have some innate immune dysregulation and inflammation. Now, one of the confounding things about all of this is the fact that just about every patient with MECP2 duplication also has duplication of another important molecule called IRAK1. So here you see the smallest region of overlap between the two black bars, and every single case, the duplication of MECP2 includes IRAK2 here as well. And why is IRAK2 important? So IRAK1 is important because it's an innate immunity signaling molecule. So you see here in orange, signaling downstream of some of these innate immune receptors. And so if you have too much IRAK1, you would think that, okay, maybe that would give you too much immune signaling, so maybe too much inflammation, or maybe somehow if it dysregulates the immune system enough, maybe you get immune deficiency as an actual result. A report just came out this year that suggests that maybe that's not the case. So this group from Europe, they studied 9 patients, and they didn't really find any obvious gain or loss of immune function in patient blood cells when they tried to activate IRAK, or when they studied the IRAK1 signaling in these patients. So that suggests that any of the immune defects in these patients are really perhaps isolated just to MECP2. But it's really hard to know because, again, this is only 9 patients, and this is the only study that's really ever looked at the IRAK1 in MECP2 duplication syndrome patients. So, um, summary from the second part of this talk is that most of the respiratory tract infections in Mecp2 duplication syndrome patients are probably associated with aspiration, but IgA deficiency can be common. Immunity towards polysaccharide encapsulated organisms can be impaired in terms of that IgG2 and polysaccharide antibodies. And the exact impact of the genetic duplication upon T cell immunity and innate immunity is still not well worked out at all. Then one early study suggests that the IRAK1 duplication might not be immunologically important, but again, 9 patients. So management. So what can we do to try to reduce some of these infections? So, I mean, infections are really burdensome. As many of you in the room know, they're really burdensome. So this study, Dr. Pelevin, showed that among different kinds of things that bother families and patients with Mecp2 duplication syndrome, here you have, somewhere on the order of 1/3 or more of patients find that infections are either the most bothersome or second most bothersome problem with this disease. So it is definitely a big problem. I do recommend checking the immune system in patients because sometimes if um, we see an immune problem, some of these can be targeted and treated. Now, just about anywhere you can do the assessment of immunoglobulin levels and polysaccharide vaccine responses with antibody responses, and even T cell assessments. Just about any immune lab in the U.S. or in Europe should be able to do those. STAT3 and STAT1, I don't know if that testing is available in Europe or the UK. There is a lab. There are 2 labs in the U.S. That will do that clinically, and then the in terms of testing toll-like receptor function and serum IL-1 beta levels. Again, the jury's out for that because that would be related to IRAK1. So what are the options? One of the first things that we do tend to do with patients having a lot of respiratory infections is start with just preventative antibiotics. And usually that's a very benign approach, non-invasive, etc. And we certainly encourage all patients to be well immunized, to be caught up on immunizations, to sometimes get extra immunizations. So there's a pneumococcal vaccine that is not given to children typically, or even to adults, usually only to elderly adults. And we recommend that at some point. If the antibiotics don't work, then if the patients have a polysaccharide antibody deficiency, one of the next logical or reasonable steps is to do antibody or IgG replacement therapy. And then if all of that fails, I think you do have to think about laryngotracheal separation to curtail some of the recurrent aspirations, because immunoglobulins and antibodies and antibiotics even won't fix the aspiration problem. And so here's an example of what one group did, this Barrow group, where this is one patient who was just having all sorts of pneumonias here in the red bars, lots of pneumonias. And then at 12 years of age, they started the immunoglobulin replacement therapy. And in this patient, it didn't seem to do a whole lot. It went down the next year, but then went up by a lot at 14 years of age. And that's when they started antibiotic prophylaxis here. And you notice that after that combination of antibiotics and immunoglobulin replacement therapy, the pneumonia has really dropped significantly. So, in conclusion, Mecp2 duplication syndrome patients and their families are often burdened by these recurrent infections, especially the pneumonias. Further studies are needed to determine the exact immune problems in all of these patients. And so clinical testing is definitely indicated and warranted. And a number of measures should be considered to decrease these infections. So I will stop there at 20 minutes, and that should hopefully give everyone time to ask any kind of questions.
Yeah, I can take the questions, or yeah, bring the microphone. Any specific question about infections for now? There's one question at the back.
Hi, yeah, thanks. With prophylactic antibiotics, is there a potential for them to wear off further into the future? You know, the effectiveness of the antibiotic?
Yeah, so that is a very good question. We always do worry about that. It's not really wearing off of the antibiotics. It's more development of antibiotic resistance, right? So there's always that potential. Sometimes, one of the things that has to happen is just rotation of the preventative antibiotics. So using one antibiotic for a period of time and then switching to a different one, and then rotating back to the first one, and so on and so forth. It takes a lot of clinical judgment and following the patient to see how the infections are doing.
Got it. And Dr. Chinn, I wanted to comment on the IVIG. I started recommending in some patients in US. They are not like my primary patients, that's why I don't refer them to you. And I think there is, like, when you calculate the number of infections, initially some families said that no, there's not too much improvement. But when you count numbers, that looks like there's a response to IVIG as well. I mean, it doesn't clear up the infections fully, but definitely there's a trend to decrease the number of infections. Any other questions?
Yeah,
go ahead, sorry.
I mean, I think that it's important, right? Because not every aspect of the immune system can be quantified, and so one of the important things is if a patient is improving with antibody replacement or IVIG, then I would definitely do it. And the pneumonias are a significant problem. So sometimes it is a matter of just throwing the kitchen sink at them until you get something that works.
Yeah. Other questions? Oh, sorry.
Thank you. Hello. My son seems to get an awful lot of mucus secretions, particularly when he's not well, and that seems to add to his upper respiratory infections. Is there a reason why that he would produce so much secretions?
Well, so that's a good question. I don't think everyone knows all of the roles of Mecp2 in the body. I mean, it's a methylation protein, really. So it can affect just about any gene, any other downstream gene. It is very possible that having excess Mecp2 could lead to upregulation of some of those genes connected to mucus production and things like that.
Okay. Or I'm just thinking whether it's too much production of mucus or not able to clear the mucus, because we all produce mucus.
But he still produces constant.
Okay, got it. Yeah. And I think airway clearance, maybe if he can't clear itself, right? Routine airway clearance, sanctioning, getting some certain therapies. I'm sure you are doing that, but yeah. Further questions? Okay, one more, hold.
So for antibiotic therapy, would it not be a good idea to start broad spectrum first, culture the infection, and then go more targeted with your prophylactic treatment?
Yes. That would be the ideal approach. Now, not every it is really hard to get those cultures, right? Because a lot of that would require a bronchoalveolar lavage, BAL, which is very invasive. So most of the time, what I do is I start with just empiric treatment. Since I know strep pneumonia and H. flu are the top two organisms implicated in these patients, I'll start my therapies with antibiotics directed towards those, and I'll work my way through things. Sometimes it is just a matter of trial and error, especially when you can't get those cultures. But if you can get the cultures, that's very helpful.
Further questions? Okay. Thank you so much, Dr. Chinn, for joining, and you have a rest of the day, nice rest of the day.
All right, thank you. Nice to meet you all. Have a good afternoon.